So today's goal is really to understand endometriosis. Now, I'm not here to tell you the things that you can already Google. I'm here to tell you the things that are really upcoming with data and what we need to know past the diagnosis or before the diagnosis. So I'm going to let everyone else introduce themselves. There's people, come on guys, come on over, just introduce yourselves. I'll just let you know he's in the hospital running behind. So he's going to come in like a straggler when he can. But you want to say hi?
Hi, I'm Kelly. I am a pelvic floor physical therapist here in Frederick. I'm in PelviRx Physical Therapy. So I am very excited to be here, and we will chat all things like anatomy, pelvic floor in just a little bit. So.
I'm Leah. I work with Rani at Women's Care. I know some of your faces there. You may see me before or after treatment for endometriosis, and we'll kind of go over some chronic pain and management of those type of symptoms afterwards.
Hi everyone, I'm Dr. Pierre. I'm a colorectal surgeon here in Frederick, and I practice with with
Rani.
Take care of babies like yourselves.
Perfect. And I'm Rani. I am a minimally invasive GYN surgeon, so I take care of endometriosis, fibroids, anything that's complex gynecology here in Frederick. So we know what endometriosis is, right? You've seen the bunch of pictures. We know that the standard definition is endometrial glands, so that means stuff that grows inside the uterus is now all over the organs, okay? And so we know it can spread from the diaphragm into the thoracic cavity. We have a bunch of symptoms there. It can spread all the way into the pelvis. There's other stories that you probably have heard where it can spread into more orthopedic areas, but this is kind of the standard definition. But let's kind of define it differently, okay? So this year, actually this has been an initiative for a while. It's now known as a chronic systemic inflammatory condition rather than a purely pelvic one. It's very important to understand that. So we all know that these are the symptoms of endometriosis. Are there more? Absolutely. Now, unfortunately, most women will end up going to a lot of different specialists for this, but they'll never kind of put everything together and say, hey, wait, I have this, but you know what? I also have this, so I have to go to the GI doctor first, and then maybe to the GYN. The GYN says everything's normal, but wait, my GI is going to do a colonoscopy. So I know it's a little bit of a fragmented picture of your symptoms, but that's kind of what we really are hounding down on, showing you that it's a head-to-toe problem, okay? Why is endometriosis so painful? Now, this is something that we really also have to understand, and this is new data, because it's the nerves. We start thinking about nerves. In our pelvis, if you look at these nerve bundles, this is just a snapshot. If I could show you the real shot, you wouldn't understand it. We have so many nerve bundles in our pelvis. We have a nerve bundle that takes care of your organs autonomously, so the autonomic nervous system. And then we have things that we have voluntary control, which is somatic nervous system. But something I'm going to pay attention to is right here. Look at those sacral nerves. Those are big nerves. Those things, yeah, he's nodding, he knows, oh yeah. That's a lot of control in your body. And guess what, that's all right here. All right here. So this is the new concept. Neuroimmune revolution in endometriosis. So neuro is nerves, immune is inflammation. Now something I want to bring to your picture is that you see a brain in there. So we know that it is systemic. How? You start with an endometriosis lesion right there, right? Pelvic pain, bad periods, really hurts, painful sex, and then it starts to really irritate your nerves. Hi guys. It starts to really irritate your nerves. When it irritates your nerves, it starts to really increase your inflammation. And when it does, it causes a lot of fibrosis, a lot of pain. And guess what? Now we're in the spinal column. Now we're right up here. That's all where the nerves are going, and it goes straight to your brain. It's called central sensitization of pain. It is a very unique concept. Anxiety, depression, everything is connected because you don't have control over those nerves because they're automated. So this is why we need to be part of a circle, okay? I know I've showed some of you the circle, but you are in the middle if you're a patient. And it's funny that we all can intertwine in any of these circles, whether we're the patient, whether we're the provider, but this is kind of the collaboration that we really need to be part of. So if you personally are an endometriosis patient, this is your team, right? If we are part of an endometriosis team, this is our team, right? We can't think unilateral anymore, okay? So speaking of a circle, that's why we're here today, to build this collaboration. And let me just jump into quick surgical management of it, and then I'll hand it over to our lovely panelists. But what's new? Diagnostic laparoscopy, again, everywhere on social media, is no longer indicated for diagnostic purposes. So you're having pain, we think you have endometriosis, someone's gonna say, hey, let me take you for a laparoscopy. That's okay, go ahead, but are you gonna take it out at the same time? You gotta ask that question. Are you gonna biopsy it at the same time? You gotta ask that question. Are you gonna excise it at the same time? You cannot just put in a camera and say, oh, you got endo, okay, bye. Let's get you on some medications. That's not the way anymore. That's unfortunately, historically, what we've done, and that's really not standard of care anymore. Even better, oh, this is my favorite slide. Hopefully it works. Yes. Now we are looking at ultrasound and MRI techniques to diagnose endo. I went to an international congress of imaging, specifically for endometriosis. Most of the data comes in from Brazil, from Europe, a lot of great advances. And they can actually catch nodules. So in our world, we call that endometriosis mapping. And we would love to do that before, right? It's a very new concept that we're starting to bring here. We're currently in development of an ultrasound program which can do endometriosis mapping. But something I want to show you there is, this is a nodule right there. I know you guys are like, I don't know what I'm looking at. But right there, there's a nodule that corresponds to this when we go inside the belly. These two are my favorite pictures. I know Dr. Pierre's like, I see it. This is a rectal nodule right there. This is the uterus right there. So if you go in and kind of just skim everything, you're gonna miss this nodule up here. And this is one of my favorite pictures, not for the patient, but you can see this is called a mushroom cap, and that's actually not a fibroid, that's a bowel. That bowel is completely obstructed with endometriosis. So these things are scary when you see on imaging, but the point is we can see it on imaging. So I'm pretty sure you guys have, Googled, Instagram, all of that stuff. So what about the saliva test? Now, this is meant to be very interactive. So anyone know anything? I've had a bunch of questions. No? Anyone heard about it? Or is it just, okay. Okay, so some people call it a spit test. So it's basically a microRNA test that came out from France. They looked at about 1,000 women, and they said, hey, we can actually detect endometriosis, even the superficial lesions. We're able to see it. It's great. But it's not validated, so we don't have it available yet. The goal of the test was to decrease the diagnostic time, which means that the onset of your symptoms to a true diagnosis of endometriosis on average is 21 years. That's the goal of getting a diagnosis really fast. We still have to think about treatment, okay? We all need to think about treatment. So, I know I've showed you some of these pictures, but that's a beautiful uterus, none of yours. I just want to make sure you know that. This is like it's pink, right? This is the uterus, fallopian tubes, ovaries, that's bowel. You can actually see the different things. And I know some of you have always seen this picture. This is one of my favorite pictures. So you can automatically see that it's pretty bad, right? Black spots, but I want to bring your attention to the white spots. So they actually start as white spots, and then they become very black. And then here you can see an endometrioma. This is bowel stuck here. This is Dr. Pierre's favorite surgery to do, right here. And then this is standard of care now. We do not burn. We do not freeze. We really have to go cut it out, which is called excisional surgery. So you see that this is the rectum right here. This is the ureter right here. If you just burn it, you're really doing nothing, and that's your nerve. That nerve is entrapped, and that's pain right there, okay? That's pain, no one's listening to you, you're pissed off, you try different modalities, that pain goes to the spinal cord, and this is how we start the whole process. But if you take it out, you're actually releasing the nerve right here. So your ureter works fine, your rectum works fine, and you now have just this scar tissue in there. But we're okay, you don't have endometriotic scarring, you just have scar tissue. So when we go in, we kind of stage it, right? So the staging, I don't like that word personally, but we'll call it stages. Stages are to see how bad it is. It doesn't mean that you live with a certain stage for life, kind of like, cancer. We don't think like that. We're going in, when we stage you surgically. So the higher the stage, the more deep infiltrating endometriosis. So big nodules, fibrosis, scar tissue, all of that. But stage does not correlate with symptoms. So please, I've had patients with debilitating pain, really bad quality of life, stage 1. And I've had just a little bit of discomfort, but mild organic dysfunction, and then they're stage 4. So please understand that stage does not correlate with symptoms. The question is why? Because of this, right? Even after endometriosis excision, we still feel pain. Why? This is why, come back to this, okay? So again, we have to think, step back and go to the entire systemic level of what we're treating, and hence why we need a circle. We can't do it in a line anymore. It's not just me, it's not just your endometriosis surgeon, it's everyone who is really looking at different aspects of the disease, okay? So I'm gonna hand it over to our next panelist. Sure.
Yes.
Anyway, this is a very informal, fun.
Rani, I'm going to take your mic.
Yes, yes. There you go. Sorry.
Hi, everyone. I'm Naderge Pierre. I am colorectal surgeon here in Frederick. And as I mentioned, I work with Dr. Paddy, Rani, quite frequently. Within the last year, we've really started to get to know each other. And I send a lot of my patients to her, particularly when they do present with symptoms of pelvic pain, and they'll tell me they've never seen anyone about this. And my concern that is raised is whether this is endometriosis related. And it's really frightening to think that a lot of these patients are not particularly heard, and the referral has never been placed until they're seeing me for something else that's related to the bowel.
It's the down arrow.
Oh, sorry. All right. So obviously, my involvement is in regards to the bowel involvement. And so oftentimes when we think about pelvic pain and other symptoms that they're having, the bowel component is also an important component that sometimes is the first reason in which I'm seeing them in the office. So it's been quoted about 1 in 10 people who have endometriosis will have bowel involvement. However, it can go as high as 30% when patients are seen in a referral center. So it just goes to confirm that there are more patients out there that have associated involvement of the bowel, whether it's the large intestines or the small intestines. And over time, obviously, this can lead to scarring and a dysfunction of the bowel, whether it's related to constipation, pain, bleeding, or associated bloating with all of this. We've kind of gone through some of the symptoms that patients may have, and sometimes can be ignored. As I mentioned, painful bowel movements can be one, bloating, bowel changes, patients having alternating constipation, diarrhea. They just seem to can't get a good grasp of what their bowels are doing, rectal bleeding, and of course, deep pelvic pain. And patients often will present with fatigue symptoms as well. So we've seen this picture, and so this is another illustration of what happens. Where's the which is the laser, I guess.
The one at the bottom.
The bottom, okay. So a nodule can be very surface, but it can also extend through the walls of the intestines and to the point where it involves the lining. And that's when we will often sometimes see patients presenting with rectal bleeding. This picture is kind of difficult to really understand, but up here is where you have the uterus, which is more towards the front. And back here is that area, the rectal sigmoid, which is the lower part of the colon, where the bowel and the uterus are pretty close together and pretty intimate. And you can imagine if these nodules are dropping themselves upon the bowel wall, how that can affect some of the GI symptoms that patients may present. Diagnostic tools, as Rani has brought up earlier, allows for the ability to identify these lesions before we get to the operating room. In particular to colonoscopy. So essentially, obviously, it's a scope that allows us to look and evaluate the lining of the colon. However, it does not allow us to look at the lining of the small intestines for those small percentage of patients who may have nodules on their small intestines. That segment of the intestines is not truly evaluated. Majority of lesions are in the rectal sigmoid, and so oftentimes, obviously, why the colonoscopy is important. Now, the colonoscopy, not only to help identify these potential lesions that may be seen, but also to rule out other things like polyps, colon cancer, or any other reasons for having rectal bleeding, aside from just endometriosis. All right, we've kind of delved into a lot of this. Obviously, history is really important. A detailed history to outline patients' symptoms, whether it's pelvic related, abdominal related, or systemic related. And imaging, we've kind of gone and talked about a number of those modalities that are important. And then, of course, laparoscopy or surgery itself. Once we get to that diagnosis, to not only look, but also provide treatment for what the tests have identified. Okay, and once again, pointing out that confirming diagnosis often historically has taken time. Several years can pass. Rani had mentioned the 21 year. That's a lot. That's a long time to suffer with a disease that could potentially, that will affect fertility, quality of life, overall. Medical management, I'm not going to focus on that. However, we're going to kind of delve into the surgical management when there is bowel involvement, where I come in when a patient actually ends up in the operating room. Okay, so there are different techniques or modes in which we could treat bowel involvement. Now, when patients have nodules or lesions, nodules or lesions that are superficial. If you remember that initial depiction of the nodule that was sitting on top of the bowel. Now, if it's a small area, very spread out, there's the option to essentially shave off, essentially removing that superficial area and removing that nodule without causing a deep injury or an actual hole into the bowel. And if it is very few and not close together or multiple, then oftentimes we can get away with doing that. However, as it becomes full thickness, thinking back to that original photo that I showed you, as it goes through the full layer of the bowel, then you can imagine it makes no sense to just shave off because you leave behind disease. And so that usually involves actually removal, a full thickness excision or removal of that piece of intestines that harbors the lesion. Not only do we remove that lesion, but also a rim of healthy tissue, because the last thing you want to do is close a hole that has residual disease in it and thus not necessarily addressing the issue. Now, We usually choose to do that oftentimes not only if it's a deep infiltrating disease, but also if what was superficial is of a larger area. So that the larger the area, that also makes the bowel integrity less or decreased, and increased risk of potential perforation if we just shave off a large area. And so removing the entire set piece of or small area and closing that hole is what is ideal, okay, as this picture will depict. Now, here's the part that can be a little bit wrought with a little bit more risk and complication. When patients have lesions that are multiple, significantly deep, or take a larger area, surface area of the bowel. That requires removal or excision. Now, if it's in the small bowel, oftentimes I would say it's an easier resection for me, as in I remove that segment of bowel and then I reconnect. However, if it involves the rectal sigmoid, if you think back to that picture that sits right behind the uterus or near the uterus, that's the segment that's closer to the end. So whenever we create an anastomosis or a connection, it involves one end and then the other end that you have to meet. And so the closer we get down into the pelvis, the much more fragile that connection is. And oftentimes that may involve a resection that is working around nerves. And you can imagine that affects the nerves that are involved with the resection. And that will change bowel habits. And that will change the frequency, the ability to the frequency and the ability to the urgency associated with bowel movements. And that's when we have to actually remove a segment of the lower colon or the rectum. Oftentimes, if we know that this is what's going to happen using those diagnostic modalities, then we can plan for that. From my standpoint, for bowel surgery, when it comes to a colon, I have my patients prep. Essentially, just like you prep for a colonoscopy, the idea is to decrease the volume of stool and also to decrease the volume of bacterial loads to allow me to make a connection, a safe connection. Sometimes that connection requires an ostomy or a bag that some patients will refer. Ideally, it's a temporary to allow that connection to heal safely and minimize or mitigate if someone potentially has a leak or separation. But this part of the procedure can be very associated with post-operative complications and post-operative changes in the bowel that has to be addressed with additional partnering members, which physical therapy is an important component when patients have these rectal resections or surgery for, whether it's for this or patients undergoing surgery for cancer. Key points. It's more common than people realize. The cyclical bowel symptoms are often a big clue. Diagnosis takes a team, we're all here. And treatment is definitely individualized. One patient may have symptoms that are not necessarily related to bowel, but once their diagnostic workup is complete, they may have implants in their bowel that was not obvious based off of their symptoms. And vice versa, they may have a number of symptoms involving the bowel, but implants may not be on the bowel as well. Thank you.
Okay, next we have Dr.
This one on, if
Haseebuddin.
that's okay.
He just came from the hospital. He's here to talk to us. Just getting ready.
Excuse me.
That's a much younger version of me. I'm sorry. That photo is probably about 12 years old. I got a bit more gray. I got married. I have 4 kids now. So.
Good.
Yeah. Well, good to see you all. Dr. Paddy, it's been, yeah, Dr. Rani is a good resource, and she's very vivacious when it comes to this and very energetic. Got the whole team together, and thank you.
Oh, no, thank
So endometriosis is a frustrating disease. I mean, it's one of those things that affects a lot of systems. We just talked about colorectal system. It also affects urological structures because those structures are nearby. Sometimes because of that causes symptoms of urination, frequency, urgency, painful urination. It's just the bladder is a bit more constrained. It cannot expand as much out. So, the worsening frequency and urgency, keeping up at nighttime sometimes as a result of that. And sometimes may require both medical therapy as well as surgical therapy. With regards to the medications, there are medications that help relax the bladder so that you can hold more. There are some symptomatic changes like limiting caffeine, soda, spicy food, alcohol. All of those can also make an impact. So that's more of a medical aspect of it, and oftentimes they require imaging, and I've seen situations where there is a lesion within the bladder, endometriosis lesion within the bladder, or sometimes because the ureters are nearby, causes an obstruction of the kidney as a result of that, and those can potentially require more of a surgical treatments. When the kidney is obstructed as a result of endometrioma, you cannot just leave that kidney to be obstructed. Otherwise, you'll lose your kidney function. Situations where I usually see some younger females who have hydronephrosis or blockade of the kidney. Generally, if it's much older population, you worry about the malignancy. But usually when you see younger females, this is not a malignant process. When the imaging does not show a stone, that's what I get fearful about. You take a look inside the ureter, there's nothing in the ureter, but it's all compressing from the outside as a result of the scarring from endometriosis, and have had to do what's called ureterolysis to free up the ureter from surrounding tissue. Oftentimes along with the procedure, you place a stent in there, which is a straw that goes from the kidney to the bladder, and the stent allows for the ureter to be protected as we free it up from the surrounding tissue. Had seen fairly good outcomes with that procedure also. Someone who's been living with a stent for some time no longer is needing of a stent after that procedure. The other places I've seen it is within the bladder itself, and as a result of implanting within the bladder, it can cause the symptoms of urination as well. And removal of the bladder lesion usually does help. Usually I've seen, for the most part, majority of the ones I just usually see one or two lesion, and if you carve out that from the bladder and close the bladder up, that does help. Usually along with that, need to have a catheter to let that bladder heal. Tends to stay in for about 2 weeks or so and take it out at that point, and usually that does help. I think with respect to the urology, there's both surgical as well as functional, medical aspect of this also, where the bladder function is as a result being affected by that, and both behavioral as well as medical options with regards to that can help.
Thank you.
Thank you.
Thank you
Anything
for
else you can add?
making it.
You're
Yes.
welcome. Thank you.
So our program includes
Thanks.
2 more speakers and then questions. We're going to try to keep it here as long as we can. But are you guys okay to keep going on? Yeah, okay. Thank you.
Oop, too far. All right. So I'm going to talk all about the role of pelvic floor physical therapy when it comes to endometriosis and different scenarios that we see with each patient. So as some of this was already mentioned, endometriosis affects about 10% Again, we kind of question that number a little bit, potentially more. But about 1 in 2 women will experience chronic pelvic pain. So this is something we see come into our clinic all the time. Oftentimes these patients have not yet been diagnosed with endo. They've kind of been swept under the rug by so many different providers. They're in debilitating pain, and it's really taking a toll on their quality of life. So that's one incidence that we see. And then others, they might be coming to us with that diagnosis, and that pelvic pain is one side effect that comes with it. So I want to get into a lot of the anatomy of some things so that everything else also helps make sense with what Rani, Dr. Paddy was saying, Dr. Pierre, what everybody's been talking about. So we understand why, when we're having endometriosis in the pelvic or even up into the abdominal region, how it can impact other joints of our body, because we see this clinically all the time. So I'm going to use my pelvic model here just to orient you all. Looking at the pelvis, this is the front part of the pelvis here, which sits right in the center. So that's kind of where the sides come together in the front. That's called the pubic symphysis. If we're standing with our hands on our hips, as we might say, that's this part. So it's actually the top part of your pelvis. Your hip is lower. If we turn this around, there's this like upside down triangle bone, and if we need to turn lights on, we can, but if everybody can see, that's fine. There's this upside down triangle bone, we call it the sacrum. So if anybody's had SI joint pain or SI pain, does that sound familiar? Yeah, so that's where the sacrum meets up with this part of the pelvis called the ilium, so the SI joint. We have one on each side. And then if I were to turn this around again, these little divots or indentations, this is where the thigh bone or the femur comes up. It angles in, it meets up with the pelvis. This is our hip joint. So the hip joint's actually really deep in the groin. It's not this like bony part over here that a lot of us think is our joint. That's where the bone comes up and then angles in. So that's where that is. The hip joint's actually deep into the groin. At the bottom part of the pelvis, so if I were to take out, in female anatomy, we have the organs, the bladder, the uterus, and the rectum. Those all sit in through here. And then if I were to take those out and we look straight down, these are the pelvic floor muscles. So you can see that in through here. We have a lot of different muscles. These examples, they're very simplistic. Kind of as Rani was saying in the nerve diagram that she was showing, there's a lot of complexities to this. And we have more superficial layers, meaning they're closer to the skin, and then we have the deeper pelvic floor muscles as we go up. But again, in female anatomy, we have 3 holes. We have where the pee comes out, that's the urethra. Then we have the vaginal opening and the rectum. So same thing on through here. Those muscles go around those openings, and one of the job of them is to keep pee and poop in when we want it in and to let it out when we want it out. They help with sexual function. But I point these out because imagine all of the diagrams that we saw, the pelvic organs are in the pelvis down through here. If we have these lesions of endometriosis all in through the pelvic region, again, potentially up into the abdominal region, there's this stuff called fascia. It's this really thin, fibrous-like material. It goes all throughout our body, and those lesions can start to impact how things move or don't move. They can be very restrictive. So we can start to get all of these issues with the muscles in through here, how they can move, how the hips move, even up to like the shoulders, the spine, everything can be involved there. If we go on to the core, so again, we talked about the pelvis and the anatomy there. The core is made up of the abdominal muscles in through the front. So we have this muscle, whoopsies. We have, keep hitting the wrong button. This muscle that goes up and down here. So when we pulled one of the layers off, you can see that. We call that the rectus abdominis muscle. It goes from the ribs down to the top of the pelvis. We have a left and one right one. In the middle there is what's called the linea alba. So that's this, like, again, connective tissue that has to lengthen during pregnancy. So if you've ever heard of diastasis recti, or the muscle separation as they call it, it's really just a lengthening of that tissue there. And then we have around the sides, we have our oblique muscles, and through here we have an internal and external oblique. And then we have our deeper core muscle called the transverse abdominis. So again, front of the core is more the rectus abdominis. We have the abdominal muscles wrapping around to the side, and then it goes to the low back and through here. These are looking at the really deep muscles of the back, and that attach directly to the spine, but that makes up the back part of our core. Pelvic floor is the bottom part of the floor, of the core, and then the diaphragm, which sits, I have a better picture here in a minute, it sits like this dome-shaped muscle up under the ribs here. So again, core is abdominal muscles, front and side, low back muscles, pelvic floor sit at the bottom, diaphragms at the top. So oftentimes that endometriosis is kind of throughout the pelvis and the core region can impact all of those structures as well from a muscular standpoint. So this is another picture of the diaphragm. Where is that? Yeah, so this guy sits up in through there. Coming back to this, I love to talk about the connection between breathing and the pelvic floor because I see this so often in our patients with endometriosis or just pelvic pain in general, that because of the pain or because of sometimes we're bloated or whether we're physically, like you can see the bloating or we feel that way, we tend to want to hold our core really tight. Think of like a pain response. We might be like tensioning everything up and that becomes our new normal. We never let muscles go, especially in this area. I see it all the time. When we hold our core really tight, the pelvic floor muscles also lock up and they follow that. And then we get a ton of tension in that region. So one thing that we work on both prior to having surgery to excise endo, after, or if we're just managing endometriosis, is breath work. Now this is one thing among many that we do, but when you inhale, if we're breathing properly, the diaphragm lengthens and lowers. Put that down for a second. So picture the diaphragm up here. Pelvic floor muscles are down in this part of the pelvis. When we inhale, the diaphragm should lengthen and lower. Those pelvic floor muscles follow. The belly slightly expands. When we exhale, the diaphragm comes up. The pelvic floor muscles go back to their resting state, and those abdominal muscles start to come back in. So we're getting this really nice ebb and flow between the diaphragm, the pelvic floor muscles, and the abdominal muscles. So what happens when we have a lot of pain and we're locking up here, we can't expand it, right? So we start to breathe upwards. We might use our chest a lot. We might breathe up into our neck and our shoulders. So I'll often see with these patients is they come in with a lot of neck pain. And they might not even tell me about anything else. Like my neck just, no matter what I do, it doesn't let go. And I watch their breathing like, why are we holding this here? What's going on with that? So it's very important that we can use that diaphragm and expand out. If that's ever something you want to practice, and there are multiple ways of breathing and different schools of thought here, but putting your hands around the lower portion of your ribs, like just barely on them, and as you breathe, you should feel them start to expand. You should feel the belly come out just a little bit, and then as you exhale, they come back in. Again, that helps you get those pelvic floor muscles to also let go. And then going back to, again, just all these muscles, and this isn't even showing all of them, but the hip joints, that's what I was talking about. The thigh bone comes up, angles in. That's where it meets up with the pelvis. We have all of these muscles from the inner thigh that go up right next to the pubic bone. We have this muscle called the psoas that goes from the front part of what's called the lumbar spine or your low back. And it comes down, meets up with this other muscle. They become good friends, and then they share this attachment down through here, and they're your hip flexors. So a lot of people feel like, oh, my hip flexors are really tight. Again, imagine all this potential restrictions in fascia and mobility from endo through here, how this is going to impact that whole area, and even coming back up into the back. And then again, just another image of the diaphragm, even more muscles coming down. Again, this doesn't do it justice. There's a bunch more than that. And then looking in through the side of the pelvis, so if we were to take the pelvis here, cut it right down the middle, take one half off, we're looking at it from the side here. So this is this part here. And then we're looking at the bladder, the uterus, and the rectum. So this is one without endo. This is one showing what that can look like. So again, just how that impacts all of those structures through there. So 3 scenarios, there's actually 4, but 3 main ones that we usually see. The one I already mentioned, somebody coming to us, they're having, whether it's bowel issues, pelvic pain, anything like that, and they have not yet been diagnosed with endo. We're kind of like their last resort of hope. They also haven't seen Rani or Leah yet, so we get them in with them. But they've kind of been swept under the rug. So that's one scenario. The other is you've been diagnosed with endo, and for whatever reason, whether it's personal decision, a collaboration between you and your healthcare provider, you've decided right now with where I'm at, surgery's not something I want to do, right? We are managing symptoms with physical therapy. We are not treating endo. There's nothing we can do, unfortunately, during pelvic floor PT that gets rid of it. It just doesn't happen. We are trying to get all of the tissues moving, reduce your pain, and it's definitely a maintenance thing where we come in, most of my endo patients without surgery come in like once a month for maintenance. We're reducing pain, we're trying to improve your quality of life. Second scenario, surgery scheduled. I want you in if I haven't seen you pre-op. I love my pre-op patients. Even if you come in for like 1 or 2 sessions, it gets our baseline. I want to see what are the pelvic floor muscles doing? Do you have a brain muscle connection? Because with those muscles, they don't cross a joint, really. I mean, not that we can move. If you think of your bicep, it goes from your shoulder down towards your elbow. So if you need to strengthen or activate your bicep, we do bicep curls. You don't have to think like, come on, let me flex my bicep. Our pelvic floor muscles are way different. There's not a joint necessarily that we can just move that contracts them. We have to, our brain has to say, all right, I want you to contract. I want you to relax, just as important, because oftentimes in pelvic pain, we get really good at contracting and then we get stuck. And it's like, I can't let them go. And then we also need to bear down for those proper bowel movements. Just like the core as well, we need to have really good brain muscle connection. So I want to get an idea of where are you at with your brain muscle connection prior to surgery. So that way if you come out after and we see like, you can actually let these muscles go again. We do a pelvic assessment, you can contract, and now you can relax. Like I know endo is playing a huge role in like holding them up more than brain muscle. And then feeling what is our tension like? What are your pain levels like? What's strength like? It gets our baseline. And we also like to help you prepare for the first 2 weeks after surgery because that can be uncomfortable, right? So we want to give you strategies on how do we breathe, how do we do some very gentle movement to manage that pain early on. And then after surgery. So that typically the first 2 weeks we're staying home. We're not coming in yet. It's again, you just want to take time to heal, recover. After that, I usually see patients around like that 2-week mark. Sometimes they come in a little bit later if they're just not feeling ready to leave the house. But depending on the time there, that's the other reason I want you in early, because I don't want you sitting still those first 2 weeks. We got to get you moving. But after that, we go through a certain protocol, like week 3, 4, 5, and so on, of how do we move? Because if we don't move, all of those adhesions start to lock up that fascia. So if you picture my shirt like fascia, if we have these structures that were really tight, they might start pulling. See how my shirt's starting to pull all the way up to my shoulder, down to my hip? Everything's gonna start to lock up, and it can feel very, very painful and lead to other joints becoming a problem. So we wanna make sure that you're moving. And then we're doing a lot of hands-on work for pain relief and teaching you things to do at home. So with a PT session, because a lot of times it's a very foreign thing, like we all kind of have an idea of what physical therapy is. Some of us, especially when people call, like, what do we do with pelvic floor PT? Like, I don't really understand what's going to happen here. So it's not much different. We always have a discussion, and I want that as in-depth as you need it to be. Some of our patients, after like 15 minutes, they've gotten out everything they need to get out with telling me. Others, it's a 45-minute conversation, and that's primarily all we do the first session. So this is really dependent on what's going on, how much you want to tell me, your history of everything, right? I want to know all the things. And then we do movement screens, strength screens, just like going back to the anatomy that I showed you. If I only look at your pelvic floor and the pelvis, I am missing a massive picture. I need to see everything. How does your spine move? How do your hips move? What's the strength of them? Can your brain talk to those muscles? Palpation, so feeling not just like pelvic floor work, but the abdominals especially. When this gets locked up, it feeds into everything and how it moves. So how do all those feel? Are we having back pain that maybe we had prior to surgery? Are the hips and glute muscles a little sore? Inner thighs? So just feeling any of those areas that you feel like, yes, I have pain here, or I have in the past. And then a pelvic exam, that's always only with the person's consent, but that's looking in through the pelvic region. And again, seeing, can you contract, relax, and bear down those muscles? I want to know what your coordination is. An internal pelvic assessment, one glove finger in through the vaginal region. We can do rectal as well if we need to, but that's feeling for those pelvic floor muscles. Are there tension? Am I reproducing any pain that you've had before? That might tell me like, okay, we took care of the endo through surgery, but we're still having some pain, so it might be a muscular thing that we need to work on. Just like if you came in with back pain, we're feeling around like, oh my gosh, that's my pain, we're gonna work that out. Same thing with the pelvic floor, just a little more intimate of an area. We wanna know the strength, the endurance of those muscles. There's so many things we're looking at with a pelvic exam. And then we're gonna go over your plan of care. So I always say, it doesn't really matter what I want for my patients. It matters like, what do you want? What are your goals? If you're like, I wanna get back to running and lifting, like we're gonna be working on it, right? If you're like, I just wanna like be able to live. I don't care about the other things. I just wanna be able to live my life, then the plan of care is gonna look much different. There's really not much research at the moment on physical therapy for endometriosis. This was one of the only things I could find. But some of the things that they find with pain reduction or quality of life that we use in PT, electrical stimulation. I use something in the clinic, it's called micropoint stimulation. This is purely clinical stuff that I see. This is not like anything that's researched back that I found with endo specifically. But it helps get the scar tissue, if we've had surgery, it gets that to move a little bit better. It reduces pain. I see that all the time when I push on an area, hurts a lot. We do that type of stimulation and then it feels a lot better. So that's a lot of my maintenance stuff that I do. Exercise, again, we've got to move. Pelvic floor PT, that's what I was talking about with doing the pelvic assessment, working out some of those muscles. And then the hands-on work, very, very important to get, again, reduce that pain, help you manage, get everything moving. And then just some examples through here, kind of already talked about. And again, it's not just the pelvis, that is one piece of it. I need to see full body, or more of what we call an orthopedic screen as well. How does the spine move, hips move, what's our strength, what's our brain muscle connection? So we're working on all of that in the clinic. And then when to start PT, prior to surgery, I mean, about 1 to 3 weeks. If it's I've had somebody come in and it was literally the following week. They came in on Tuesday, like my surgery's next Tuesday or was it next Friday or something like that. Wonderful. Like having that at least one session prior to. Ideally, we get 2 in, but 1 is just as good. So somewhere around that time frame before surgery. After surgery, as instructed by your surgeon, it's usually around 2 weeks. Again, before 2 weeks, you need to sit at home and kind of recover. It can be a little bit uncomfortable. And then non-surgical management, if you either think you have it, know you have it, as soon as possible. Don't wait, 'cause again, we want to try to manage those symptoms for you. Cool, questions? All right. Leah.
Thank you, Kelly. I've heard her lectures. How many people contracted their pelvises when she was talking? Oh, come on. I know I did. So I just wanted to introduce Leah, and I want to commend her. I want to commend her because she's brought this program specifically for endometriosis, and she's done a lot of work, and she's, I think, one of her kind in our community, but she brings us all surgeons together and all pelvic floor together. So I'm hoping you're going to get as much as I get from her lecture. Here you go. Wait, Kelly, can you put this on her?
I can just hold it.
You can
Put it on, yeah. I don't know, I've met some of you. I see familiar faces. You may see me in the office with Rani. You often will see me before diagnosis and then after diagnosis to kind of help manage that pain that's still lingering there underneath. Or maybe you've been coming to GYN for years and you just say, oh, I have chronic pain. I've just always had that. That's just my normal, right? So we do your well woman exam and you just say, oh, nope, my periods are always like that. That's just normal for me. That's what we need to talk about and realize that might not be normal, right? You shouldn't be living in chronic pain. And we want to help you get to a better place in life where you're not living uncomfortable all the time. So let's look into this just a little bit here. And so when you start talking about chronic pain, what is that? Chronic pain is more of a long-term, 6-month type of pain cycle. It's not acute pain, you just injured your foot and your toe healed in 2 weeks, right? Chronic pain has been there for a long time. You've been trying to manage it. You may have been to GI and you may have been to Uro and you may have been to, GYN, all trying to figure out where that pain is coming from. And when we look at our body, there's multiple different ways to diagnose it, right? And all of this is connected. Everything in our body is connected. So my job is to try to figure out where is your pain coming from. That comes from you telling me what your symptoms are, how long have you been dealing with it, what are your menstrual cycles like, what is your diet like, what is your lifestyle, what is your sleep cycle like. All of those things contribute to our pain response and how we perceive pain. So it may seem like a lot of questions we're asking you when you come in for your appointments, but I need as much information as you can give me so that I can map that pain and figure out, do I need to get you into GI? Are you having those type of issues? Is there some IBS underlying? Do you have bladder concerns? Have you had recurrent urinary infections? Is there something going on there that we need to address that's underlying? I'll have you often see the pelvic floor physical therapist to see, is this muscular? Is this bone? Where is this pain coming from? And then we'll look for those signs. You can have other things in there, right, that are causing your chronic pelvic pain that may be GYN related, like endometriosis could be there, but you could have adenomyosis, you could have fibroids, you could have ovarian cyst, you could have had recurrent infections, and those are just some of them, right? And we can also have just painful dysmenorrhea, which is more of a regular painful menstrual cycle that comes and goes with your menstrual cycle. And we can treat that as well, but that may be separate from endometriosis. So trying to figure out where is yours coming from, okay? So the more information that you can tell us, it's going to help us figure out how to treat you a little bit better, all right? And then these are some of the symptoms we need you to be aware of. You've seen them in everybody else's slides as well. You could have multitudes of these. And how often do they occur? How much is the urination? Do you have stress incontinence? Can you hold your urine? Are you bleeding through? What's your normal bleeding pattern? Are you bleeding a tampon or pad an hour? Is it lasting more than 7 days? That's too heavy of bleeding, right? Are you bleeding through your menstrual cycles? Are you bleeding in between them? Does the diarrhea get worse during your menstrual period? Do you get constipation during your menstrual period? All of those things are going to help me figure out what first steps we need to take, or if I need to get you in to Rani, or if we need to get your ultrasound done first. We often will start with that so we can rule out some of those anatomical concerns with the ovaries and the uterus, okay? But just because you have a normal pelvic ultrasound does not mean that you don't have endometriosis. She went over a little bit of, the limitations with the current way that we do ultrasounds. You can miss that outlying endometriosis, okay? During the physical exam, you're probably used to having a well woman exam where we're doing a pelvic exam. We probably don't explain it very well to you, right? We're doing a speculum and we're taking your pap smear, and everybody just thinks that's the pelvic exam, right? That's the only reason you're coming in, you just need a pap smear. As we were talking about a little bit earlier with the pelvic floor muscles, when we're going in to do your pelvic exam, you can have focal tenderness, oftentimes in that lower left rectal region. If you're having pain in that area on intercourse, I can often recreate that, not that I want to, but if I do your exam and I can feel that there and you have focal tenderness in that lower left quadrant, that may be where the endometriosis is. Or is the bladder fixed? And when we do your exam, it doesn't move well, okay? So if you have less mobility in that pelvic floor on your exam, there may be some scar tissue or adhesions or endometriosis on there, those little nodules that are stuck adhering to everywhere. So pelvic exam can be very helpful, okay? But you can also, like I said before, have a normal pelvic exam and you still have endometriosis. But if your pelvic floor is too tight and you can't relax that pelvic floor, and you go to see Kelly for physical therapy, she's like, hey, wait, they are so tight down there, I can't get them to mobilize, I can't get them to move. I may need to help you with that and give you some vaginal estrogen sometimes can help, okay? So we have little tricks and things that we can do to help you get to relax those muscles so that we can get you through those processes. We talked a little bit about diagnosis with Dr. Paddy. She went over a laparoscopy and doing ultrasounds and how we diagnose the endometriosis. But then when you get to me, we're often trying to deal with the pain afterwards, right? And we're targeting this inflammatory process that develops in our body. And this inflammatory process has been going on for a long time. This is often years, right? And it's taken years to get it diagnosed. So we're not going to be able to just quickly turn off that inflammatory response in the body. So my goal is to figure out how can we get your inflammation back down, right? We have good inflammation and bad inflammation. And that chronic inflammation, especially around nerve endings in the pelvic floor, we want to try to calm that down. We can heal our bodies ourselves, right? Our body is very smart, but we have to give it the things that it needs to be able to heal. So we know that we need water. We know that we need good exercise. We know that we need mobility. We also need good nutrition, right? So we have these little things called free radicals that are running around in our bodies. And when we have too much oxidative stress in our bodies, from damage to the body, from alcohol, from surgery, from medications, other chronic autoimmune disorders, right? We've got all of these processes causing damage in there. And you release these free radicals, and when there's too many free radicals and not enough antioxidants in our system to balance them, we have more pain, more inflammation, and that process continues, okay? And you just continue to have inflammation. So we need to slow that down, right? There's lots of things that we put in our body chemical-wise that are not good for us, okay? So we're going to touch a little bit on that. I think that's my next slide. I might be jumping ahead just a little bit. All right, so that's what the anti-inflammatory diet comes in, right? We want to get you healthy again so you feel better, so you have better energy, so you can get more exercise, so that you can sleep better. And what I sit down with you is go over any underlying medical issues you might have, okay? Because supplements are useful, but they're not first line either, right? We can take supplements that can help us with inflammation, but we want to try to get as much as we can from our natural food, from whole, fresh foods, all right? This will be good anti-inflammatory foods on the left-hand side, which we've probably all heard about. We can go a little bit more in depth with those here in a minute, and then we have pro-inflammatory foods on the right-hand side, right? So we know a lot of these things. Fried foods, commercial baked goods, anything with corn syrup in it is an inflammatory product, right? We have to really read labels well to know what we're putting into our body. All of this contributes to oxidative stress throughout our entire system. And when we think about our bowels, right, if our bowels are unhappy and we have constipation and diarrhea and we're going to GI and they're trying to get us to, feel better, we can take stuff out of there and we can correct the endometriosis. But if the underlying bowel's still inflamed, we're still feeling bloated, we're still having constipation, we're still having diarrhea, all right? So we need to get that bowel system calmed back down so that it can digest, so you can absorb nutrients. Because if our bowels are chronically inflamed, we're not going to absorb what we need, okay? And we need those good positive antioxidants to help reduce those free radicals in our body, all right? And everybody's triggers are going to be different for them. And those are other things I need you to write down for us. When you eat, what makes you constipated and what gives you diarrhea? Just because you eat dairy and it gives you diarrhea, it may not be that you're allergic to dairy. It may just be that you were so inflamed you cannot digest that casein protein. It's a difficult protein to break down. All right, so we have to take you back down to whole basic foods, get the body calmed down, and then slowly add foods back in that can help you, okay? These are just some supplements that actually have research-based evidence behind them. There's lots of supplements out there on the market. You have to be careful with supplements. I do not recommend just going to a pharmacy or a grocery store and picking up a supplement and take it. Everything we put in our body has potential side effects, and especially if you are on thyroid medications, a lot of people are, right? We know that there's a lot of interactions with thyroid and our thyroid medications. Some of these can be dangerous if you don't know what you're taking and what you're putting in, right? But they can also be helpful in down-regulating our nervous system and getting rid of neuropathic pain, inflammation, helping our bowels move. And these are just some of the ones that potentially I might use for you depending on your history, okay? But we would do a detailed recall of anything that you are already taking, what kind of dietary plans you're already on, and we would make some adjustments to help get you into a better dietary program, okay? And you can see the difference. I like to point out like the dosages on the supplements and how much you would have to eat of something to, let me see if I have my one that I want. I'll go a little bit over those too, but so to get enough of sulforaphane, 5 to 10 pounds of raw broccoli daily. I don't know about you, but if I eat 5 to 10 pounds of raw broccoli daily, I'm going to be really inflamed and bloated, okay? I'm going to have a lot of gas. So sometimes we need to start some supplements to boost up and get some of that protective response from them while slowly introducing some more fresh broccoli and things into the diet, right? So there is a role for supplements in the anti-inflammatory diet, but the goal is to get your overall diet better in the long run. Some general guidelines for some diets that can work are like the Mediterranean diet. We always kind of go back to that. It has low saturated fats. It has healthy oils in it. You always want to stay away from seed oils. You want to lean towards avocado or olive oils when you're eating. Try to stay away from canola and vegetable oils, okay? I'm kind of getting off topic a little bit. Yeah, and so we want to build like a whole plan between myself, Rani, GI, Uro, and try to figure out what are the best things that we can implement into your dietary plan to kind of help you get inflammation down. And then I didn't touch on like NSAIDs. I kind of skipped over that slide just a little bit. But there are medications that may be involved too that I may help you with your chronic pain as well. But my goal was to not have you on a whole bunch of medications. The goal is to get you feeling better, kind of calm that inflammation down so that you don't need so many pain medications. But there is a role for like hormone suppression, NSAID use for anti-inflammatory use, especially in the short term to help with the process, okay? questions? I know that was a lot really quick. Okay. Yeah. And then just always use supplements with consultation, okay?
So guys, we're going to take a 5-minute break, but please don't leave because the next part's a lot of fun. It's a
Okay.
lot of talking amongst all of us. We're all going to hang out.
I skipped over some of the good stuff. I was going too fast.
So all the panelists are going to come back. We're going to answer any of your questions you want. But there's a lot of room for patient advocacy and some patient stories. I really want you to be part of that because that's the main thing.
Now I can have coffee.
Sitting in a lecture room and sometimes, but I think the next part is going to be huge for us. Okay, so 5 minutes.